Welcome back, everybody, to part 2 of our Cazden Visiting Scholar Day. For many of us, it's actually part 3 because we've just had our fellow interactive session with Dr. Newburger. I trust that many of you had an opportunity to dial into her fantastic grand rounds this morning. My name is Lars Gross-Ortmann. I'm the Division Chief for Pete's Cardiology, and I'm honored to introduce her one more time for the second didactic lecture that she's going to give to us. Dr. Jane Newburger is the Commonwealth Professor of Pediatric at Harvard Medical School, and she's also the Associate Chief of the Department of Cardiology for Academic Affairs. She is incredibly accomplished academically, as all of us are well aware. She's authored more than 500 papers, reviews, and book chapters, including 11 papers in the New England Journal of Medicine. And if you're interested in vasculitis and more recently COVID-19, you know her from her extensive work in that domain. If you're interested in lifelong outcomes and epidemiology, and especially neurodevelopmental outcomes in congenital heart disease, you're familiar with her work in that space. So we took advantage of both of those incredible areas of expertise for Dr. Newburger, and we will be hearing her talk on neurodevelopmental outcomes beyond mortality. And just to kick us off quickly, what we're talking about is the outcomes of people with congenital heart disease have really improved dramatically through the eras, and the chances of reaching adulthood for many of our patients is overwhelming. However, it is now becoming, in addition to keeping these patients alive, the question of how they survive and what their outcomes are from a neurodevelopmental perspective. So with that, I would like to hand the floor to Dr. Newburger and ask her to present to us.
Thank you, Lars. Can you see the slides?
Yes, we can.
Okay, hold on one second. So Lars started to give a little bit of my talk. This is a really old slide of the New England Regional Infant Cardiac Program, which was one of the, I think it was the first collaborative in the United States of New England states, where you can see that if you took all infants who came to attention either through cath, surgery, or other means in the first year of life with critical congenital heart disease, their survival was only 63%. And if you had hypoplastic left heart syndrome with aortic atresia, it was 0%. And this is a wonderful iconic slide of Gil Lenofsky's that looks at how how survival is improved for literally every lesion, VSDs, TETs, transpositions, and hypoplasts, so that patient survival is expected. This is also a rather dramatic graph, which shows you the age of death in patients with congenital heart disease in Quebec province in Canada, contrasting survival in 87, 88, where you see this huge peak in infant mortality, with that from 2004 to 2005, where you really expect most people to live into adulthood. And with that, increased survival, just as Lars just said, it really exposed the fact that so many of these patients have neurodevelopmental morbidities and problems with quality of life. And in fact, behavioral and developmental and neurologic abnormalities are the most common comorbidity in children with congenital heart disease, more common than late sudden death, significant exercise restriction limitations, significant arrhythmias, unplanned reoperations, and endocarditis, even all combined. We know that the prevalence of neurodevelopmental impairment is affected by disease complexity. So the severe impairment, which you see in the dark gray, becomes more significant as you go from mild to moderate to severe to the palliated newborn to syndromic patients. And really only a small proportion of syndromic patients have no disabilities. So we group these into low risk and high risk categories for development of neurodevelopmental challenges. A lot of effort has gone into what causes neurodevelopmental disabilities. It's hard in the current day not to talk about genetic abnormalities first off. As of about a month ago, 50% of congenital heart defects can be linked to genetic abnormalities. And those can be aneuploidies like Downs, microduplication or microdeletion syndromes like DeGeorge that this child has, or single gene disorders. And we also know that de novo point mutations, meaning those mutations that aren't in your mother or your father, contribute to about 10% of severe congenital heart disease if you do whole exome sequencing. It's probably higher with whole genome sequencing. In the Pediatric Cardiac Genomics Consortium, which is a consortium of 5 primary centers around the United States, which is now in its 3rd funding cycle. This was way back in 2015. Jason Homsey looked at 1,213 trios of parents and child with congenital heart disease, and looked to see what proportion or contribution was made by damaging de novo mutations. And this is a bit complicated, but about 2% of what are called controls here, these are congenital heart disease patients who don't have multiple anomalies and don't have neurodevelopmental abnormalities, have damaging de novo mutations. But if you take this red bar group that has not just CHD, but also neurodevelopmental disability and congenital extracardiac abnormalities, that number rises to 20%. And that suggests that there are genes that sort of contribute not just to heart, these are high heart expressed genes, but also contribute to these anomalies and neurodevelopmental issues. We also know a whole lot more about fetal cerebral hemodynamics independent of genetic abnormalities. And we know that fetuses with some forms of CHD have reduced fetal cerebral oxygen delivery, and that affects brain growth, maturation, and metabolism. This is very early work by Kathy Limperopoulos, who's now at DC Children's, but was then in Boston, in which she studied, she was the lead investigator in a study that took children with various forms of CHD and then comparison fetuses. This is a cross-sectional study, meaning that each child was only studied once, and she plotted total brain volume against gestational age. What you can see is that the slope of these lines diverges so that the control patients had an ever-increasing growth rate, but the growth seemed to be slower, and I use growth carefully because, as I said, this is cross-sectional, but it appears that there is going to be slower growth in the CHD population. This shows the relationship between the N-acetyl aspartate to choline ratio, and this has an exponential curve in the normal population of fetuses in the same study who are diamonds versus a much slower rate of rise in patients with congenital heart disease. And those with dark circles didn't have antegrade arch flow and were hypoplasts. So they already had some evidence of lactic acid accumulation. This elegant work was done by Mike Seed's group in Toronto, where they looked at estimated brain weight Z-scores in fetuses, and they compared that to the estimated cerebral oxygen consumption and the estimated ascending aorta saturation. And it appears that as your cerebral oxygen consumption goes up, so does your estimated brain weight Z-score, and same thing with saturation. Again, looking at oxygen delivery as a main potential factor. Dan Litt did a really nice study at CHOP, and here you see on your x-axis the total maturation score, which looks at 4 parameters of maturity: myelination, cortical infolding, involution of glial cell migration bands, and presence of germinal matrix tissue. And we know from preemies that this score goes up. So these are normal preemie data from Childs that were published some years ago. What Dan did with his group was to then take term babies with congenital heart disease and see where they plotted in this score. And so his study patients are in red. They were born at an average of 39 weeks. And if you then take them across to the maturation score and then extrapolate it back to your gestational age, you can see that they are about a month behind where you would expect them to be for their maturation. And a lot of people have said that dysmature brains in children, particularly with transposition and hypoplastic left heart, are a little bit like preemies, but perhaps it's just that they're dysmature. And we can't ever ignore the fact that heart disease itself is associated with neurodevelopmental sequelae and changes in the brain. Chronic severe cyanosis, malnutrition, arrhythmias, cardiac arrest, endocarditis with emboli, those all can cause brain damage. This was one of my very first ever studies where we went back through neurodevelopmental testing in the New England states to look at how this is kind of a preschool IQ test called the WIPSI, varied with the age at which your mustard was done. And you can see that, in fact, the later you were done, the worse you did in IQ. And that was statistically significant even when you adjusted for social class. It's just that the mustard procedure, which was done in those days, came to different hospitals at different times in the region. We also know that strokes occur. So this is an 8-year-old boy who suddenly developed left-sided weakness, and he was found to have a right hemispheric thalamic lesion that you see on the T2 weighted map, TRACE, and ADC. But what was interesting is if you went to other parts of the brain, if you did your cuts in other regions, you saw that this child had had silent infarcts in the past, well before the onset of this particular stroke and hemiparesis. And that's something that we see in Fontan patients, both clinically apparent and silent infarcts that can happen separately or even be seen in the same patient. We know that there are sequelae of the cardiac interventions that we do, and millions of NIH dollars have been devoted to preventing neurologic damage in cardiac surgery. And of course, if you look at an operating room, it's kind of a hematologist's nightmare. You have the potential for macroemboli, microemboli, and hypoperfusion. Janet Soul at our institution in our hematocrit trial was the first to show these these hemosiderin lesions, these tiny little black dots, which we now know and has been reproduced pretty much everywhere you find in 25% and up of children with severe congenital heart disease, and seems to be related to the length of time on bypass and also to the number of interventional cath procedures. They also look a lot like what you see. They're probably microhemorrhages or little microemboli with tiny little hemorrhages. You also see something like this in shaken babies. Then how does maturity affect the risk of white matter injury. So first, we know that 20% of newborns have white matter injury on MRI even before they go to surgery, and that 44% have new white matter injury after surgery. John Becca showed in a beautiful study from Down Under that white matter injury was most common in babies who had immature brains, meaning that particularly that they were preterm or early term, and that to the extent that we're able, that really encourages you to prevent obstetricians from doing elective deliveries before 39 weeks. We also know that there's some data that show that white matter injury is more common in newborns that have a longer time to cardiac surgery, probably just from being blue and exposed for a longer time to the ICU environment. It's hard to remove that from any confounding by indication that kept them in the OR for longer. And then finally, whereas a tremendous number of NIH dollars went into randomized trials of bypass techniques, we now know that really both before and the post-operative hemodynamics have a very profound effect. In the first 24 hours after hypothermic bypass, you have impaired cerebrovascular pressure autoregulation and reactivity to CO2. So you really can't, your vascular ability to kind of regulate blood flow to the brain is impaired. And this makes you much more vulnerable to hypotension and decreased cardiac index just in the time when those things are the most prone to happen. Just to emphasize difficulties with the post-op course, these are data from the Boston Circulatory Arrest Study where children were followed from birth, children with detransposition, simple detransposition with VSD or intact septum. These children are now being followed all the way to age 28 years. We just finished the 28-year follow-up. But this is an 8-year study, and we divided their hospital lengths of stay into quartiles to avoid the effect of outliers. The red bars are verbal IQ, the purple bars are full-scale IQ, and you can see this steady decline with longer length of stay, almost of the magnitude that you might see with lead poisoning. This association of longer length of stay remained strong and significant, and this was a prospective study. The kids were seen in the newborn period in the ICU every day. And so even when you adjusted for the things that the events like sepsis that might keep you in an ICU for longer, and the parent factors like social class that predict worse development, and you took out the top 5% of outliers of length of stay, each CICU day was associated with lowering by 1.4 points in full-scale IQ and 1.6 points in math achievement. This is very sobering. We did another study. This is Bill Molly led a study with a question of whether your development was better if you had a hypoplastic left heart, if you had staged palliation versus a primary transplant strategy. And instead, what they found was that the most important determinant of IQ was, again, the longer you stayed at your first surgery, the lower your IQ score was. And it didn't matter which pathway you were going down. We know that pretty much every anesthetic that we use in the cardiac OR is affected by a black box warning. There's been a lot of study of that as well. And we know that just very short anesthesias don't seem to have a big effect. But for our cardiac kids that have long and multiple anesthesias, we can't be quite as sanguine. So then in summary, the causes of brain injury are additive and they interact. You start with innate factors, then preoperative factors of brain maturity, hypotension and hypoxia, operative factors of hyperperfusion, micro and macro emboli, and anesthetic agents, and then postoperatively, again, you can be hypotensive, hypoxic, Kids get sedation. They may not be as well nourished as you'd like, and they may have general morbidities. What's interesting is that even if you take sort of all the long-term studies and large studies that have looked at risk factors, the measured postnatal risk factors that we can see every day only predict about 30% of the variance in how that child turns out later. And importantly, when adjusting for patient and preoperative factors, in multiple studies now, bypass and postoperative factors only contribute to at most 5% of the variation in outcomes. So what have we learned so far about neurodevelopmental phenotype in children with congenital heart disease? We know that there is a sort of a signature of these children. Motor skills, particularly gross motor, but also fine motor and oral motor, which goes into apraxia of speech, tend to be affected. Visual spatial skills, vigilance and sustained attention is an issue. Higher order language. So children can speak, but if you show children a number of pictures and you ask them to make up a story, we know that that ability is delayed. And then we'll talk a little more about executive functions, but executive functions is what we call upon for all of us every day as we kind of prioritize and organize. We have to keep things in our working memory, and we have to apply principles to solve problems. And that requires integration across a number of areas of the brain. This simple test turns out to be pretty predictive. This is called a Ray-Osterreich complex figure, and it tests visual spatial motor function, and also requires crosstalk across many parts of the brain. So you put this figure in front of children, and you can see you have to discern that there's a little diamond, there's a little face, that there's a square with components within it, and you ask the child to copy it first, and then as you do the full ray, you ask them to reproduce it from memory 1 minute later and 15 minutes later, and it is really hard. But the average second grade student, if you just ask that student to copy it, will produce a figure that looks a little bit like this. What we found in our circulatory arrest patients is they did so poorly that our psychologists had to devise a completely new scoring system to get everybody a score. And you would think, well, nobody needs to do that when they grow up. Why is it important to reproduce a figure? But in fact, how you performed on the ray was highly associated with your need for receipt of remedial services in second grade. So the worse you did, the higher that rate of remedial services. Executive function, we just talked about. What parents will tell you is Johnny is impulsive, has trouble waiting, or Jeannie has trouble waiting her turn. Cognitive flexibility, gets upset by changes in plan, gets stuck even when the solution seems obvious. And then working memory, leaves his lunchbox, hat, and jacket at school every day, or give him more than one direction at a time, and he's completely lost. So this is how parents might describe in an 8-year-old. We know that that is a huge area of difficulty. Attention deficit disorder is also, and most of the cardiologists will have seen this in their practice, that CHD is associated with higher rates of ADHD. Most children with CHD can be safely treated with medication. So it's really rare that you would sacrifice treating a child because you're worried about their heart. On the other hand, it probably organically isn't exactly the same as some of the other kinds of ADHD that you see in regular children in the population. So there may be a different mechanism, and you still try the same drugs, but they may not have quite as high an efficacy. So you might ask, well, what does it really matter, honestly? But it seems that self-control has a very important effect on how you turn out later in life. And this is an amazing study, the Dunedin study, where they took 1,000 individuals, 1,37 children born in one city in 1 year, and followed them from birth to age 32 years with 96% retention. It wasn't like the city of Boston where people move so much. And they looked at children's self-control during the first decade of life, and then got reports from observers, teachers, parents, and combined them into one composite measure of a self-control score, and then fast forwarded to see how they did by the time they were adults. And they found, just to get this is hard to see, but children had worse general health. The worse that you did in your score, the worse your health, your wealth, the more likely you were to be a single parent, and the more likely you were to have crime. And that was true even when you adjusted for social class and IQ, that childhood self-control predicted those physical health, substance dependence, personal finances, criminality in adulthood. So deficits in social cognition were first described by David Bellinger, who is just an amazing psychologist in Boston, who came from the discipline of looking at toxicities, toxins in the population, and we convinced him to work on the Boston circulatory arrest, trial by telling him that really bypass was kind of a toxin, which didn't turn out to be. But he first described deficits in social cognition. And what is social cognition? It's kind of the processing of social information, the ability to interpret social situations and relationships. It's the ability to read the emotions of others. It's what you do at a cocktail party or a post-work party, and it doesn't always track with intelligence. He tested them with a test called the Mind in the Eyes test, where there are 34 pictures of facial expressions in the eyes, where you might be, you have 4 choices here: aghast, insisting, bored, or cautious. This guy looks like George Bush, and the right answer is cautious. Nobody is perfect at this. This is a really, really hard test. And honestly, I think there's some better tests today. But if you looked at the general population, you see a skew, even in those who never had heart disease. But our DTGA patients scored way at the bottom, and the Fontan adolescents, this is at age 16 years, Fontan adolescents were even worse. To better understand the organic underpinnings of what we found in transposition, we did brain MRIs in teens who had been in BCAS, or the Boston Circulatory Arrest Study. And if you looked at their routine brain MRIs, they looked by and large quite normal. But with diffusion tensor imaging, you could see that they had reduced what's called fractional anisotropy, which indicates white matter injury. And that white matter injury was quite widespread. The degree of white matter injury was very related to clinical risk factors that we know about. And we thought that probably some of the cognitive dysfunction that we saw in this group was affected by this kind of disruption in white matter abnormalities, which we now know. We chose transpositions for a trial of circulatory arrest or low flow bypass because we thought they were otherwise normal, and we now know that in fact, because they get such blue blood to their brains, that they in fact are born with quite a bit of white matter disruption. Single ventricle patients have the greatest number of risk factors for adverse outcome. They have genetic abnormalities, congenital CNS abnormalities, circulatory collapse, chronic cyanosis, congestive heart failure, problems with nutrition and growth, multiple catheterizations and operations. And if there is such a thing as the psychosocial impact of chronic disease, this is a group who would have that. In this, the single ventricle reconstruction trial was a trial of patients of two ways of doing the Norwood procedure in children with hypoplastic left heart syndrome. And that group of children has now been studied up through early adolescence, but we have looked at their neurodevelopment at each time point. And here you see what their Bailey scores were like at 14 months. And you should have a kind of a normal distribution for PDI and MDI around 100 in the era that they were studied. You can see that the average, actually we do the median Bailey for PDI score was 72, which is almost 2 standard deviations below what's expected for normal. MDI scores were a little better with a median score of 92, so that's kind of an infant mental development, more like an IQ score or cognitive score. In multivariable analysis, that Bailey was most highly related to two things: your innate patient factors, whether you had a genetic syndrome or other anomalies, lower maternal education and lower birth weight, and also to greater morbidity in the first year of life, so longer Norwood length of stay and more complications between the Norwood discharge and 12 months, but not to any factor of intraoperative conduct. It was interesting that the 4 biggest centers, which were CHOP, Wisconsin, Michigan, and Boston, all had incredibly different intraoperative conduct, but Bailey scores were almost superimposable in these kids. At 3 years, we just did screening by the Ages and Stages questionnaire, which screens for enough disability that you need to have real testing and intervention. But rather than 2.5%, you can see a way high percent that's screened in the at-risk range for communication, gross motor, fine motor, problem solving, and personal social. If you fast forward, we're going to have more on neurodevelopment at 10 years, where 10 to 12 years these kids have come in for in-person testing, and those data are just being analyzed now. But we did a study in Boston with 155 Fontans in adolescents and found again that this was the most severely affected group, but particularly executive function, that 4 out of every 5 children in this group had some impairment in executive function. And if you looked in general across neurodevelopmental scores to see what factors, so this is including IQ, achievement, ADHD, neurodevelopment, the risk scores for worse outcomes in our adolescent Fontan group across the board were being younger gestational age, genetic abnormality, here longer time on bypass, so longer total support time at your first operation and longer circulatory arrest time. These were hard to separate from being a hypoplastic left heart as opposed to another type of single ventricle patient. More operations, more operative and cath complications, and a worse history of seizures. How about psychiatric or mental health diagnoses? So in our adolescent Fontan group, if you did something called the Kitty SADS, and you looked at a lifetime diagnosis of any disorder, we found that 65% of patients in the Fontan group, compared to 22% of what were supposed to be normal, actually better than normal controls, had any such history. Mood disorders were not significantly different, but anxiety disorders were much more common in the Fontan adolescents, as were disruptive behaviors, which were primarily ADHD, which was present in 34% of the Fontan group compared to 6% of the referent group. We also did structural brain MRIs at Fontan in this group. 144 kids could comply with that. Some kids couldn't get into the scanner. 66% of those in the Fontan group compared to 6% in the referent group had any type of abnormality. And 60% had at least one focal or multifocal abnormality versus 1% in the referent group. 13% of the kids had had a prior stroke, and not, I would say, I have to go back, but about half, they had been silent. 54% had those little hemosiderin lesions, those tiny microembolic events. And then diffuse abnormalities were also a little bit more common in the Fontan group. Interestingly, developmental abnormalities were the same. There was no significant difference. We found what we did here, this is Mike Rifkin's group in our neurology department. These are maps of cortical volume and cortical thickness where you took all the normals and all the Fontan patients and you superimpose them and subtract them from each other to see what areas light up. And cortical volumes and cortical thicknesses were diffusely lower across all lobes in the Fontan patients compared to the normal controls. This is all worrisome because and pediatricians, we tend to think about neurodevelopmental burden in a developing brain, but our patients are living to be adults, and unfortunately all of us will get acquired both cardiovascular and brain disease, and you get more of a cerebrovascular lesion burden. And I think many people have probably read that there's a higher incidence of dementia in the Danish data in congenital heart disease patients who are adults. So what can we do to help neurodevelopment in children with CHD? In the ICON study, we got pooled data from pretty much everybody who would agree to participate, sent us their published data, like individual items, on 1,770 subjects gathered from 22 centers in 6 countries, and with surgery, open heart surgery below age 9 months of age, between 1996 and 2009. And then those data were analyzed. We took out, particularly looked at the Bailey 2s at a mean age of 14 and a half months. And you can see the PDI scores are down here. They're the dark circles, and the MDI scores are the light circles, the light diamonds or open diamonds. And the scores, when you adjust, the scores did go up over time. So this is adjusting for lesion and other known risk factors for worse outcome, but they're still pretty darn low. That leads you to look for what else could be causing trouble and what can you do about it. I think we do need to better understand genetic and epigenetic causes of neurocognitive disability. There have been now 15,000 probands in the Pediatric Cardiac Genomics Consortium, and those are whole exome sequencing, and it only accounts for about 1%, 1.5% of the genome. We still have to learn a lot more about what's in whole genome sequencing, which is sort of the dark part of the genome. And it is a fair question to ask whether, if you know early enough, genetic abnormalities could someday potentially even be a modifiable risk factor. Then there's what I call déjà vu versus vujade, or environmental toxicities. So déjà vu is when you walk into a room and you've never seen something before, but you're sure you've been there before, you've seen it before. Whereas vujade happens when you've been in the same situation a zillion times, but suddenly you see something for the first time. And I think that really has happened with ICU care, where we understand that the noise, the pain, and especially recently, a lot of concern about plasticizers and exposure to phenols and phthalates Bill Gaynor has done work where he's measured those in the urine of patients post-op, and they are like sky high, an order of magnitude higher. And even G tubes are associated with higher plasticizer values. I think there's been a very big emphasis on excellent developmental care in the ICU to try to protect babies from overstimulation, stress, noise, pain, and bright lights, to promote sleep by clustering care to the best extent that you can, to try to manage pain with less drugs, using sucking, rocking, holding patients, more skin-to-skin contact as you walk through our unit. You see more babies on mom's chests, and involving parents so they can really bond to a greater extent as their babies are in the ICU for long periods of time. I know in our ICU, Samantha Butler, who is one of our developmental psychologists, actually does simulations with the nurses for better developmental care. And there are some randomized trials that are now ongoing. How about medical interventions? I think there are trials in Toronto going on to see whether you can improve brain oxygenation with maternal O2, a CHOP using progesterone. I think a trial of progesterone. I think we all know that we should avoid early term delivery now. Some people have wondered about antioxidants, although there are no trials that I know of. There's been a big interest in CICU people and the surgeons about adjusting your care based on perioperative brain monitoring. And although nobody really does jugular venous bulb measurements anymore because it's just too hard, you'll see many ICUs around the country are monitoring with NIRS, MEG, or EEG. That's a typical looking baby. In 2012, the American Heart Association came out with guidelines on developmental care, and it recommended, and again, this is consensus, routine neurodevelopmental screening and testing of high-risk children with CHD, and education of patients and families and schools. And recommendations very specifically were for early intervention services and early childhood special education services for all high-risk children, which for cardiologists is many kids we care for who had surgery in the first year of life, plus anybody who had a neurologic event, ECMO, transplant, and other conditions. The recommendations are for formal developmental and medical evaluation at 12 to 24 months, 3 to 5 years, and 11 to 12 years of age. And then after age 12, an evaluation plan that is determined at the discretion of the medical home provider, which is very often the cardiologist, especially for the most complex patients. Younger adults should be referred for higher education or vocational counseling if they have any difficulty. There's also interest in interventions. This is a CogMed working memory intervention, but there are a number of kind of active interventions that people have been interested in that perhaps help working memory. Wherever you start from, making sure that that transition from fetus to infant to child to adult focuses on well-being. And sometimes in the counseling we do, it means directing your patient into an area that realistically they can succeed in. Sometimes that is vocational training, but it makes for happier patients if they can actually accomplish what they set out to do. Throughout the field, there is collaboration and dissemination, and it's really a beautiful thing to see over the years. So CNOC, or the Cardiac Neurodevelopmental Outcomes Collaborative, now we just had our 10th meeting. It's really a fantastic group of people across the country who are now gathering data and trying to do the same kinds of neurodevelopmental testing, especially in young children, to put into a large database that then can be linked with other databases, including STS, PC4, and other registries in what's called Cardiac Network United. I'm sure you participate in MPCQIC, which also has a module for Fontan patients in particular. The NIH's Pediatric Heart Network and its Pediatric Cardiac Genomics Consortium have a great deal of neurodevelopmental data collection. And then the worst eponym of all is the CHPHC CNPQ, which is a CDC initiative that also is focusing on well-being and neurodevelopment. For all the concern that we have about development and neurocognition in CHD patients, whenever you give rounds somewhere, there's always a resident or a fellow or a faculty person who's doing beautifully and brilliant who has congenital heart disease. And in fact, when we talk about problems, we talk about the askew of a curve, but many individuals do beautifully, and in fact, the majority are doing well developmentally, and more ACHD patients have a bachelor's or a graduate degree than haven't graduated from high school. And the hope is that with the innovations and better care that we have now and a better understanding of how to help the brain develop normally beginning in utero, that we expect over time that each CHD patient ought to be able to reach his or her own best full potential. These are a couple of my own patients with permission, PhD now with detransposition intact septum, and a lawyer ethicist who has hypoplastic left heart and Fontan at age 35 years. And I'm going to stop here just for any questions. I hope we have a little bit of time. Thank you.
Thank you very much, Jane. That was a wonderful, albeit very sobering overview of the topic. We have time for questions. So I'd like to start with Debbie Berger's question here in the chat, who's wondering if iron deficiency anemia in pregnancy has been studied related to neurocognitive outcomes of the patient.
You know, I don't know the answer to that. I have never heard of a study about iron deficiency in moms. I think the body is an amazing thing, and my guess is that you compensate for that with higher maternal cardiac output, but I don't know. I've never seen a study on that.
While people are thinking about questions, one thing that often comes up for patients in whom there's some neonates, in whom there's some flexibility as to when to submit them to cardiopulmonary bypass. And we know, being small, being early, et cetera, is a bad thing in terms of outcomes. But, the two lesions I think about is transpositions with a VSD where, we have some flexibility to wait. And now neurodata is suggesting it's maybe not that good to wait, even though we're thinking we're doing a good thing by postponing their surgery out of the neonatal period, and maybe that's not right and has detrimental impacts on their brain. And the other population that we have some flexibility is a group with normal oxygen saturations or oftentimes only mildly decreased oxygen saturations, which are the total veins. Unobstructed, where we have some freedom often to do them a little later. What are your thoughts on those two?
Well, I think in terms of transposition VSDs, it's complicated. In our study, in the Boston Circulatory Arrest study, and in Mike Seed's most recent study that was in circulation, that's a group that does worse. They also tend to go to the operating room a little bit later, more so in Toronto than Boston. And sorting out how much is delaying the surgery versus something different genetically about those patients, particularly because those patients aren't as blue, right? You can wait because they have better mixing. I would say that the weight of opinion has moved, at least for transposition, to doing early surgery because the risks of surgery don't seem to be very different. And people do worry that perhaps simply waiting too long could have an adverse effect. We won't really know the answer for sure without a trial or without a big enough study that you could propensity match. In terms of patients that aren't blue and when is the optimal time for surgery, again, there's great debate among institutions. I would say generally the best time for surgery drives the day, so that if you take a patient with tetralogy, because the actual operation becomes harder, once they get tremendous RV hypertrophy, we usually will operate, at around 3 months now, rather than, even though you could wait a year in some tetralogies. What we don't know is whether the tet who does so badly that they need something done in the first month of life, when presumably the brain is more vulnerable, whether they do better with a shunt and then an elective operation later versus a primary repair. And I haven't seen a great answer to that question yet.
Thank you.
So I'm seeing a question in the chat from Amy. In your experience, what is the best way to disseminate this information to community pediatricians to ensure the message of importance of early intervention and referral to rehabilitation? So that's a really complex question, and it was one that was dealt with and discussed a lot just a couple of weeks ago in the CNOC symposium, because we know that around the country, even when you do your best, a huge number of patients don't seem to go for early rehab and don't get referred for services and don't come back to cardiac neurodevelopmental programs. I think the pediatricians are pretty busy, so you have to make it really easy for them. And brochures that they can hand out in their offices. What we do in our program is that the discharge orders from the cardiac ICU include an order for developmental evaluation before the time the baby goes home. And then our developmental psychologist, Sam Butler, and also Jane Singer, we have two, evaluate the child, write something up, and make a referral for early intervention before they go home. Even with that, it doesn't always happen, but it probably improves your likelihood. I think the parents are probably more reliable in following through than very, very busy pediatricians. And so educating parents, being sure, and parent groups now, like Mended Little Hearts and Tiny Little Hearts, and the various wonderful kind of parent advocacy groups, the Children's Heart Foundation. I think getting the message out parent to parent of the importance of this is another way that you can make follow-up a little bit better. We also have posted in our clinic, we have brochures in each clinic room for our cardiac neurodevelopment program. And we're about to deploy a kind of a quality improvement project in which auto text every clinic notes asking about neurodevelopment from the pediatric cardiologist will be surveyed as a quality metric. Did you ask how the child was doing? Did you ask if the child's on an IEP? Did you ask about milestones? And having some auto text for us that's in Cerner, most people have Epic, to make it a little bit easier for generation of your letters. So those are just a few things that you can think about.
I wonder if I might ask a question.
Yeah.
Dr. Newburger, hi, Stephen Back. I loved your talk. I thought it was remarkably comprehensive in terms of thinking about both the prenatal and the antenatal factors and the environmental factors, right down to how you care for the patients in the nursery. Um, I was really intrigued by your observation that maybe about 30% of the factors have been identified that might be causing the neurodevelopmental disabilities in this patient population. I was wondering what your thoughts are about other fetal factors, which seem to be increasingly coming to the forefront. You know, mothers with sleep apnea, for example, or other forms of intermittent hypoxia, maternal fetal infection, that tend to fly under the radar screen, perhaps because they're hard to monitor.
I think everybody is, most people are focusing on one of two areas. One are fetal factors or in utero factors, and that includes placental health, their maternal morbidities like diabetes or smoking or obesity. Sleep apnea is another one. We know that those can actually impact survival. Uh, so we hypothesize that maybe those have epigenetic effects, but don't really know for sure. And then the other is the whole field of genetics, which we just learn more and more and more every day. Cerebral hemodynamics is another, that if not enough blood flow gets to certain parts of the brain, or the blood that gets there is profoundly blue, then you will have a more dysmature brain. And those factors have not been haven't been put into any of the regression equations. A known genetic syndrome, yes, but so if somebody has 22q11, that kind of genetic syndrome is accounted for, but the much more common genetic syndromes or genetic factors like de novo mutations are often just not recognized early on.
We have time for one or two more questions. Dr. Williams.
Hi, thanks for the talk. This was great. It's actually what struck me is that a lot of the outcomes you presented are very similar to the kids with traumatic brain injuries and other forms of brain injuries that we see and follow those same outcomes long term, and just our general IC population without heart disease. So it's really striking how there's so much overlap, which brings me back to what I'm interested in, and what are the things in the ICU you think we can do to improve those? What are the neuromonitoring devices that you're using in your unit? EEG, NIRS, ultrasound, what are you guys doing? And then are you doing routine imaging on these kids as well?
So we do NIRS. So every baby has NIRS, and we have, we're about to be doing a lot more EEG. So those would be the two main modalities. We have not, and I wish that we did MRIs before and after as a clinical measure. And I know Texas Children's does it. Dina Andropoulos has everybody in that magnet. And you could do that if you have an anesthesiologist who's committed. But short of that, in a busy program, it's hard for us. We just haven't been able to justify it as a clinical tool. And so we haven't used it, but I do think it's a fantastic research measure. We are trying to do all those noise, sound, folding, sleep interruption maneuvers. There are great simulations that Sam Butler does with our nurses. And I think parent bonding is a terrible problem for some of the sickest kids. And so working on that bond is also super important any way that you can.
Yeah, I agree with you. I think that the MRI question is interesting because we don't even do that for kids with identifiable brain lesions on a regular basis. But you also particularly need that DTI sequence to see the white matter injury, which is really when I think where the money is the white matter injury in those kids. Yeah.
I think that's right also, although many times young kids with white matter injury wind up, in fact, having some gray matter as well.
Absolutely, yeah. The other question I had for you on your neurodevelopment program is you mentioned the specified times that you recommend these follow-up evaluations, but what about all the setbacks in between? Are you guys bringing them back in to do intermittent developmental screenings if they have an unplanned readmission or a separate surgery that might set them back.
Yeah, it gets to be too much. So I think if you find that somebody has real problems, then you will see them more often. And we have a neurologist. We have a pretty big cardiac neurodevelopmental program, thanks to some very generous donors. And we have a neurologist whose passion is cardiac neurodevelopment. And so she sees them along with our psychologist. But I think it's a burden for families are busy. And only we wouldn't routinely see kids more often than those guidelines. We would if there's a reason that it's really important.
Fortunately, we're at the hour. Before we say goodbye, I would like to give the mic to Dr. Mark Reller, who I'm filling in for today, as he is our champion for the Cazden lectureship, and he wanted to address you with a few words before we adjourn.
Welcome, Jane. Sorry not to be more actively involved today, but as we spoke earlier today, I'm recovering from a fairly major spine operation. But I want to make a couple of comments. As you know, this professorship was funded by a family back 50 years ago, in honor of the memory of an infant born with transposition. Now, obviously, the prognosis in 1970 for transposition was quite a bit different than it is today. But their goal was for us to enhance our education by bringing in experts in the field, and so we can improve our understanding of congenital and acquired heart disease and improve the care that our children receive. And this being near our 50th anniversary of the program, we discussed who we might invite this year to come out here. And it was an easy choice to pick the premier pediatric cardiologist in this country, which I feel, quite frankly, is you, Jane. Your international reputation as a clinician, a researcher, a teacher, an educator, and a mentor is unsurpassed. So we very much appreciate your taking time off on a busy day and week that you have to spend some time with us and to educate us. So I want to express my appreciation for you and for your taking the time to be with us here today. Thank you so much.
Well, thank you very much. It's been great to see so many old friends, and I hope everybody has a good day. And if I can answer any questions, don't hesitate to email.
Thank you very much, and thanks also to everybody for attending and participating and the interaction. It was a wonderful Cazden day. All good things have to come to an end, but we'll do this again next year, hopefully in person.